is Rami Mansour. I'm a second-year medical student here at Philadelphia College of Osteopathic Medicine. Today, I'm presenting a unique case of cardiac arrest due to severe left main disease treated with PCI rather than CABG. This presentation would not have been possible without the help of Dr. Junaid Alam, Dr. Irshad Sayed, Dr. Anam Zara, and Dr. Harris Ahmed. So let's go ahead and get started. Just put here some learning objectives. Number one is to understand the management of cardiac arrest. Number two is to understand the management of left main disease. And number three is to assess the impact of Impella devices during PCI for left main disease. All right, as far as for introduction, I'm just going to go ahead over a few terminology here that I'm going to be using in the presentation. Myocardial infarction, or MI, is a narrowing of the coronary vessel leading to inadequate blood flow to the heart and thus causing hypoxic damage to the muscle of the heart. Now, there's two subtypes to myocardial infarction, or MI. There's the STEMI and there's the NSTEMI. The STEMI is a complete blockage with an ST segment elevation detected on an EKG. The NSTEMI is a partial blockage with no ST segment elevation on an EKG. VFib, or ventricular fibrillation, chaotic electrical activity that could be linked to MI and also can cause a cardiogenic shock. And now cardiogenic shock is a severe drop in the blood flow due to the heart inability to pump blood, and thus you have low perfusion to all the organs. Now, treatment indicated for MI is usually either a PCI or a CABG. PCI is a percutaneous coronary intervention, and CABG is a coronary artery bypass graft. The way it goes with a PCI, and I have a demonstration I will show. With PCI, there's a catheter. Go ahead and show the demonstration. There's a catheter on the right PCI. Usually a catheter is inserted through like a femoral artery or other arteries, depending on where the occlusion happens. And then you have a balloon that inflates, kind of opening the occlusion a little bit, and then a stent is employed. And then the CABG, which is a more invasive surgery that is shown on the left. The occluded part is basically bypassed by installing or attaching a vessel from different parts of the body, from the pre-occlusion to the post-occlusion parts of the heart. Could be a saphenous vein. Most of the time, it's also like an internal thoracic artery. The PCI is of less invasive surgery. Just wanted to note that. All right, let's go ahead and talk about the case presentation. So we present to you a case of cardiac arrest secondary to VFib in a patient diagnosed with severe left main disease managed by PCI. This patient is a 50-year-old female with a medical history of hyperthyroidism. She smokes tobacco and has obesity. The medications that taken by this patient are methimazole, 10 milligrams, and she recently discontinued atorvastatin, 80 milligrams, due to transaminitis. Now, this patient, the whole incident happened. This patient was at the airport. They passed out, and they got picked up by the ambulance. And the initial EKG findings, they found out a VFib and a prompt initiation. They started the CPR and they started defibrillation. The CPR or defibrillation continued until ROSC was achieved after 4 rounds of CPR. And the post-ROSC EKG showed no ST elevation. So the patient was intubated. It started on an antiarrhythmic medication, and then it was transferred to the catheterization lab. So we have lab results here. We can see that we have the TSH low, and that is, again, due to this patient being diagnosed with hyperthyroidism. The T4 was elevated. The troponin was elevated as a hallmark for MI, and the WC, or the white blood cells, were also elevated. The hemoglobin was low. All right, so this patient, after administering a coronary angiograph, it confirmed that we have a 90% left main artery occlusion. And to manage this patient, they did a PCI surgery using a drug-eluting stent. And of course, an Impella was deployed during the procedure to support the blood flow. And now I have a demonstration of what an Impella looks like and how does it work in the next slide. But post-catheterization echocardiogram showed an ejection fraction of 31 to 35%. After removal of the impella and after successful extubation, the ejection fraction was 60%. And the patients was put on lisinopril, aspirin, atorvastatin, and metoprolol. Now, right here, we can see the impella here, and basically what it does, it assists with pumping the blood in the weakened area of the heart because of the occlusion. It also can be inserted in as a catheter, and it's not a permanent thing. It's just during the procedure. As you can see here on the right, this is a post-drug loading stent. You can see the blood flow going in after the implementation. So this case, the uniqueness about this case is that it's a left main disease that was complicated by cardiac arrest and cardiogenic shock. Usually, indication for procedures or diseases like this is a CABG, which is the much more invasive surgery, but it's more of a traditional standard surgery that has been supported by a lot of studies for its continual success, and it's for the post-surgical outcomes. However, more and more cases and more studies are coming out supporting the PCI, especially when it's used along with an impella or with a drug-eluting stent. So here in this case, a PCI was used, and it was able to restore the blood flow to the cardiac and support the cardiac function. I wanted to highlight here two studies. One is the Syntax. The Syntax has compared the PCI and a CABG in a cohort of patients, and it found no significant results in the difference in the outcome of these two studies. But more recently, we have the Excel trial that compared the PCI with everolimus eluting stents to CABG in patients, and it basically looked at three factors that are composite endpoints of death, stroke, and the secondary myocardial infarction. And they found that PCI is a viable alternative to CABG in selected patients. Of course, further studies are needed, especially with the development technology. And PCI procedures are not what they are right now a decade or 2 decades ago. So future research can look into the evolving technology and the approaches of the procedure, considering now we have better technology, so it can be less invasive, it could be more efficient at the same time. Also, we can look at the subtypes or demographic qualities of the patients and which subgroup of patients can have this procedure done on them with less complications. So these are all comparative studies and comparative effectiveness to understand where we can have PCI approaches done successfully. And this concludes the presentations, and I have references for the studies that I put in these presentations. And if you have any questions, please go ahead and